Okay. Hopefully everyone has had the opportunity to log in and can hear us and has their audio set up. My name is Shauna Madelon. I'm very pleased to present to you our third APDR Roundtable webinar of this academic year. This will be the last one of this calendar year, so the next one won't be until February, so look out for that one after the holiday season. This topic will be excellence at a distance, practical skills to elevate remote radiology. We have two wonderful, well-known radiology educators here with us today who are going to teach you some tips and tricks for optimal remote teaching. We have Dr. Nina Miucin, who is the Director of Musculoskeletal Education at Vanderbilt University Medical Center, where she leads curriculum innovation for the radiology residency program. Her teaching career spans both in-person and remote formats and has earned her multiple Teacher of the Year awards across various institutions. Her educational approach is rooted in evidence-based strategies that prioritize psychological safety, level-specific instruction, and modeling intellectual humility. She believes that meaningful learning arises not from technology or proximity, but intentional design and authentic human connection, principles she applies to cultivate confident, curious, and capable radiologists. We also have Dr. Rohini Nadgir, who is an associate professor of radiology at Johns Hopkins School of Medicine. She's a neuroradiologist with a particular interest in remote teaching. For 13 years, she has been educating trainees at Hopkins in Baltimore, Maryland, from her home office just outside of Boston, Massachusetts. She is the recipient of numerous resident and fellow teaching awards and is the primary author of the 4th and 5th edition of the Neuroradiology Requisites textbooks. So without further ado, I'm going to hand it over to our two panelists who will give you some presentations, and then we'll have time at the end for Q&A. So if you have any questions, feel free to put them in the Q&A section or in the chat, and I will help moderate at the end. Thank you.
All right. Good morning, everyone. I'm going to configure my screen here, try and get it as accurate as possible. All right, Shanna, can I get a thumbs up? Sweet. Pull this to the side. All right.
Looks perfect.
Oh, let me get rid of us. Okay, great. All right, so good morning, everyone. Thank you so much, Shanna, for the lovely introduction. My name is Nina. I am the Radiology MSK Education Director at Vanderbilt, and I want to start with a confession. I've earned Teacher of the Year twice. Once teaching in person at my previous institution, and once teaching entirely remotely here at Vanderbilt. Same person, different setup, same outcome. And that taught me something really important. What I'm about to speak about has nothing to do with PAC system, nothing to do with being in the same room. It's all about how you engage with people and how you connect with them and how you treat them. Keeping in mind that residents are people too. So this is an actual quote. Don't just take my word for it. Here's something that one of my residents said. It's more effective than in person, not as good, better, it's more effective. Why? Because when you do remote teaching right, you actually remove a bunch of barriers that we didn't even know existed. We didn't even know that they were there. The physical intimidation of someone standing over your shoulder, the performance anxiety of being watched, all of that body language judgment, those are stripped away. And what you're left with is pure teaching, pure learning, and pure connection. So today we have 5 principles that I want to focus on. These are all backed by research, all things you can actually use this week, not theory. These are real practices that actually work. And we're starting with the foundation, psychological safety, because honestly, nothing else matters if you don't have this. This is key. So the learning zone model. Here's what I learned teaching remotely. The camera doesn't create distance at all. You don't even need a camera. Not having a camera doesn't create distance either. Hierarchy does. The screen doesn't block connection. Fear of judgment does. When residents don't feel safe, they spend all of their energy looking competent instead of actually becoming competent. And that's why psychological safety isn't some soft skill. It's everything. It's the foundation that everything is built upon. So most medical education lives in what's called the anxiety zone, that top left. We have incredibly high standards, as we should, but low psychological safety in that area. Residents learn through fear. They're terrified to say, I don't know, because what if that tanks their evaluation? So they end up guessing. They pretend, they hide their mistakes. Now, the opposite of anxiety, the anxiety zone, isn't lowering your standards. That's the comfort zone. And that's not what we want either. The opposite is the learning zone. High standards, high safety. This is where residents actually push themselves because they trust the environment will support them, not punish them. And then there's the apathy zone. Low standards, low safety. That's where morale essentially goes to die. So am I just talking here, or is there evidence? There's actual evidence. There's research that backs this up completely. One study looked at over 13,000 residents. Those who felt psychologically safe were 3 times more likely to report high satisfaction across the board. Not just feeling good, actually learning outcomes. And on the right, this bar graph we have here, it shows patient safety. That's the key. That's what really matters. We see that 84% of residents felt comfortable speaking up to their peers about safety concerns, but only about 48% safe speaking up to attendings. And that's a problem. When residents can't admit they're uncertain about questions or even ask a question, patients are the ones who suffer, ultimately. So how do we create this? How do we create this psychologically safe zone? It starts with your words. Small changes result in massive impact. Instead of saying, what's your diagnosis, which makes them immediately panic, try, what do you think is going on here? You're opening a door instead of demanding that they walk through it perfectly. Instead of saying what findings support your interpretation, which feels more like a cross-examination, try something along the lines of, what are you seeing here that makes you think that way? Now you're inviting them into their own thought process, creating their own process for themselves. Instead of, you missed this finding, try, let's explore this area together. What do you notice here? You just turned a missed finding into a learning opportunity, a failure into a discovery. It's becoming a partnership at this point. These aren't words. They're fundamentally shifting the power dynamic. You're not interrogating, you're inviting them in. And remotely, this matters even more. You don't have body language to soften things. Your voice and your words become essentially everything. So this week, just pick one. I'm challenging you to just pick one language swap. Try, what do you think's going on here, instead of demanding a diagnosis. Watch what happens. Watch the residents relax. Watch them actually think out loud, and think instead of performing for you. That's the learning zone. That's where teaching becomes transformative. But psychological safety doesn't just happen. It's built on relationships, not small talk. It's built on relationship architecture. So the first day of any rotation, I typically spend 10 to 15 minutes, if not more, just talking, if there's room for that. Oh, let me exit this. Okay. I ask them simple questions. Where are you from? What got you into radiology? What scares you? What excites you? What are you excited about? Some faculty think I'm wasting time, not just at my current institution, but a bunch of people from various institutions. I personally think it's the most important 15 minutes of the entire month, the entire rotation, however long you have a resident for, because I'm not teaching cases for 4 weeks. I'm starting a 4-year relationship, a 4-year partnership. These residents will rotate through MSK again. I'll see them on tumor boards. They'll ask me for letters. They'll become my colleagues eventually. So those 15 minutes, that's not small talk. That's relationship architecture. The memory system. Now, another confession. I have a photographic memory, but only for faces. I'm terrible with the details that come with those faces, personal details. So I'll remember you instantly, but did you tell me that you're getting married or that your dog died? That's harder for me. So I use AI. After each resident session, I'll document everything. What we talked about, what they're into, what's happening in their life, What are their strengths? What are their weaknesses? What they want to focus on? And in the next rotation, I'll ask AI to summarize the previous rotation, and I'll pull those notes up. And I'll ask Sarah, hey, how's your trail running going? How's your mom, David, after surgery? And they light up because someone remembered, someone took the time to write down or to take note of their personal details of their life and brought it back to them, cared to speak about it once more. So technology doesn't replace the connection, it enables it. It gives me a photographic memory for the things that actually matter. So the evidence, the research is clearly obvious on this. One study implemented a mentorship model in surgical residency. At the 1-year mark, residents showed significantly lower emotional exhaustion, lower depersonalization, higher personal achievement. The quality of life improved across every domain that was measured. Relationships aren't just soft skills, they're essentially survival skills. For residents trying not to burn out, for faculty trying to find meaning in their work, and for patients who need residents who can still show up as humans. So this week, 2 things. I know I'm giving you a lot of assignments, but I think we're up for the challenge. 2 things. First on the left, block out 15 minutes at the start of your next session, not for cases, for actual connection. Ask about their lives, or just leave leave space for conversation to exist. Just listen. Second, take notes. Write down one thing that each resident said, their interests, their struggles, their wins. Start building your own system, and the next time you see them, use it. That's how you build relationship architecture. Now, these relationships let you do something critical. They let you teach to where the resident actually is, not where the calendar says that they should be. So same MSK rotation, completely different approach for juniors and seniors. With the first year, I'm reading every single finding, every single one. I repeat concepts over and over. You see something weird, ask yourself, what stress caused it? Real world analogies make things stick. We're building a foundation here. With 4th years, upper levels, I flip everything. I flip the whole model. They lead the readout. They present to me. They tell me what they think. And when something is complex that comes up that they don't know or that I don't know, I use strategic humility. I say, I don't know, teach me. You teach me. This isn't fake. They're months from attending life. They need to practice being attendings. And honestly, I need to get comfortable not being the smartest person in the room. So moving on. There's a 5-step structure that I've developed. It's not my own, but it's formulated over a bunch of different things that I've surmised over my short-lived teaching career. So if you want structure, here's 5 steps. First, get commitment from the resident. What do you think is going on here? Not demanding a diagnosis, just inviting them in. Second, probe their evidence. What are you seeing that makes you think this way? Now you're seeing how they actually think. You're getting a window into how their mind is putting these facts together. Third, teach the principles. This is where you share the systematic stuff, the patterns, the knowledge that transfers, the things that you can relate to them. Fourth, reinforce what they did right. Be very specific. Exactly, that's the key feature most people miss. Usually people don't remember subchondral cysts, but you did, great job. Fifth, tackle gaps together. Let's explore this together. Let's Google this together. It's a partnership, not correction. Same structure every time, but here's the thing, the content changes completely by level. So juniors get the basic patterns and then seniors get more complex differentials, and the framework continues to adapt. So analogies. I love using analogies. They make complex concepts stick. One of my favorite ones is bones. Bones are dumb. Bones are silly and they don't know what they're doing. So bones react to stress. You see bone abnormality, ask yourself what caused the stress. Inflammatory, neoplastic. Vascular flow, that's plumbing. MRI sequences, different camera settings for different information. These aren't dumbing down tactics. They're connecting abstract radiology concepts to familiar experiences. And that's how learning happens. So a little story time. I had a resident, we'll call them Alex. Third year, super bright, really curious, but Alex had this habit of taking over readouts, asking tangential questions that would derail the teaching and just make things really difficult for everyone involved. So I gave honest feedback on the evaluation. I thought it was entirely anonymous, and it turns out this particular one was not. So I raised concerns about some knowledge gaps and the way that questions were being phrased by the resident. And the feedback crushed Alex. I watched the light just dim, quieter, more withdrawn, less engaged. The spirit was gone. I didn't back off though, but I also didn't pile on. I kept treating Alex like an adult, took things slow. I let Alex steer when ready. I stayed professional, stayed respectful, and made it clear that hard feedback wasn't a rejection, but it was an investment in their growth, in their professional and their personal growth. Gradually, things shifted. Alex is more focused now. Questions are more thoughtful, less taking over, more actually contributing. We're not back where we were in the beginning. We're somewhere better. We're more mature and more self-aware. So I guess the lesson is that sometimes the most caring thing you can do is give difficult feedback and then stick around for the rebuilding, not avoiding the hard conversations afterwards, because there will be multiple. Not lowering your standards, but staying in a relationship while someone does the really hard work of growing up. That's keeping them in the learning zone. And even when it's uncomfortable and difficult, they tend to stay in that learning zone when they feel supported throughout their growth. So another assignment this week, practice matching your teaching to where your people actually are, where your residents actually are. With juniors, try one real world analogy, make something abstract click. With seniors, flip it. Ask them to teach you. What happens when you make them the expert? Teaching to their developmental level, not in their training year. That's the difference. Now, the adaptive teaching requires something that makes a lot of us uncomfortable. This is probably will be the next most controversial slide. But I want everyone to get used to saying this. The most powerful thing that you can say in a teaching session is, I don't know. Let's figure this out together. Most of us were trained to hide uncertainty, to project confidence, to never admit gaps. We learned that I don't know means you're weak. But that's not what real expertise looks like. Real expertise acknowledges uncertainty and shows you how they deal with it. That's the skill. Not knowing everything, but knowing how to figure things out, knowing how to approach difficult things. So what does this actually look like? I don't know. This thing is rare. Let's Google it together. You're teaching them that looking stuff up isn't cheating. It's how medicine works. This is tricky. Let me show you how I'm thinking through it, even though I'm not sure. You're making your brain visible. They see your process, uncertainty, and all. I was uncertain about a case like this last week as well. You're showing them uncertainty doesn't magically disappear with experience. What would you do? Or what would you look up to feel more confident? You're essentially teaching them to recognize and handle their own uncertainty. Show the process, not just the answer. That's how you create people who can adapt, not just follow algorithms. The research backs this up. When researchers interviewed doctors who were nominated by their peers as doctors in excellence, humility kept coming up as the main thing. One of them said, you have to know what you don't know. I completely agree with that. Another study surveyed medical students, almost 99% response rate. They really valued exploring uncertainty with faculty. They wanted to see how you explained what you didn't know while still taking care of patients. Humility is expertise, not weakness. And remotely, when your voice and words are everything, saying I don't know out loud becomes even more powerful. So this week, yet another assignment. Find one moment, just one moment to say, I don't know out loud. And someone has to be in the room with you, preferably a trainee. Then show them your process. Google it together, work through it together. Look up the guidelines, let them see your process. They'll remember that moment way more than any other case where you knew everything, because you showed them what real expertise actually looks like. So we've covered psychological safety, relationships, adaptive thinking, adaptive teaching, uncertainty. Now let's come full circle and discuss why remote teaching done with these principles can actually be better. So I've learned a few things. When you do it right, I think it actually is better. I don't think it can be better. I think it actually is better. Even if you're reading remotely from the next room in the same building. Reading remotely removes the physical intimidation. No one's hovering over your shoulder. It removes body language judgment. No one's watching you sweat, literally. It forces you to be explicit with your words, since you can't rely on gestures. Residents control their own screen, which gives them autonomy. You have easy access to your whole case library, some things that you might not have on your local workstation in the hospital. And geography doesn't matter anymore. Expertise is democratized. All of these things remove barriers to actual real human connection. Yeah. And yet again, the evidence hammer. The research is really clear on this. One meta-analysis over 6,000 students found that equivalent or superior outcomes in the virtual learning setting were found. Another study found screen sharing was strongly preferred over in-person. And that study on the far right, and shows a survey of over 13,000 residents, showed a 3 times higher satisfaction when psychological safety was high. Technology enables, certainly, and it allows humans to connect. And I firmly believe that is what helped me get to talk to you guys today. So a few common questions. These might answer some questions that would come up during the Q&A session, but I know what you're thinking. There's obvious objections to this, and some of them we can tackle here. One concern might be we don't have enough time. Actually, psychological safety saves you time. Less remediation, less conflicts, less people quitting. You're already spending time putting out fires. This is just prevention. Virtual isn't good. The evidence disagrees. When done right, outcomes are equivalent or even better. Residents need to toughen up. No, they don't. They need support. You don't build resilience by surviving hostile environments. You build it by developing competence in safe environments. My faculty won't change. That's my favorite one. You don't need everyone. You just have to start with a few willing people, maybe even just one, and show the results. Peer influence works better than mandates anyway, in my opinion. These aren't impossible problems. They're just problems that have workarounds. So your one thing, you get to pick. Don't leave here trying to fix everything and everyone at once. Just pick one thing, one language swap, 15 minutes for real connection, one analogy, saying, I don't know. That's probably the hardest one. Trying screen sharing, giving them their autonomy back. Start small, build momentum. Small changes can compound. Because here's the truth, residents, they're people too. We have to treat them that way, and everything else follows. And that's it. Thank you. Happy to answer any questions. And yeah, ultimately, it's about creating the conditions that real humans can learn and grow and ultimately take care of other humans as well, our patients. And that's it. That's all I got.
Thank you.
Hopefully I didn't get disconnected. Okay, great.
That was perfect. Thank you so much. We're going to move on to Ro, who's going to share now a little bit more like some hands-on logistical type things we can do as well.
Okay, I'm going to share my screen. So hopefully you are I don't think you're seeing my correct screen. Sorry.
That looked good.
What? Oh, it did? Okay. Let me try that again. Sorry. Screen 3. Okay, you're seeing the same thing, I guess.
Yes, it looks good.
Okay, great. Well, thank you, Shauna, for your kind introduction, and thank you, Nina, for that really beautiful illustration of how to approach the human interaction, be it virtual or real life. And I've been doing remote teaching for 13 years now, so long before COVID. And over these years, I've come to find skills that work for me at the workstation in terms of speaking to trainees and educating. I've also come across strategies that don't work, but I'd like to take a few minutes of your time to share insights that I think that do work well for me. I have the following disclosures. Most importantly, I want to emphasize that I don't have any financial relationships with the teleconferencing platforms that I'm going to talk about today. So I'm going to begin with a brief discussion on the challenge of remote teaching. I'm going to then focus the talk on remote teaching strategies at the workstation, and then finish with some action points that might be useful for trainees. So making remote education work is an effortful process, and we want to, as best we can, simulate that in-person side-by-side experience as much as we can. The desire to make this relationship work primarily has to come from you, the educator. And it takes time and effort and patience and flexibility to be able to do those same things that are much more easily done in the face-to-face setting. But with a little bit of effort and a little bit of practice, I think that we do have the tools readily available to us to make this a positive experience for both parties. So in general, taking a step back, and this refers to, a lot to what Nina was talking about, we need to recognize that trainees are already placed in quite a vulnerable position, right? They're learning a completely new trade. They are tackling imaging interpretation, accurate reporting, communicating with technologists and other clinicians, and in many cases on a trial by fire basis. And it's important for us to recognize the position that they're in and provide empathy and respect for that position. Particularly when you're in a remote setting, they don't have a direct visualization of you as the educator, and they potentially may feel abandoned or demoralized and not as able to get the most out of their educational experience. So it's incumbent upon us as the educators to recognize the vulnerability of their position and do our best to minimize the negative impact of that on their educational experience. I do feel that if the trainee is acknowledged, heard, and valued, you can make the remote training experience work for both parties. The main crux, the main teaching pearl, I would say, is that communication is the key to making the successful relationship work. So I start off my day by humanizing the interaction with my trainee. I'm going to start off with a greeting, get to know the trainee, as Nina mentioned, talk about where they're coming from and where they've been, and do they have a cat, and those kinds of things can really personalize your experience with that person. I like to take down one barrier that is pretty easy, and that's that of hierarchy. I like to work on a first name basis. So I tell the trainee that, if you're comfortable, please call me Ro. Please call me by my first name, because I think once that we have enough barriers between us as it is. So let's take out that hierarchical aspect of things so that we can be on the same level and speak to each other as colleagues. I do ask about their background and their level of experience, particularly if it's my first time working with the trainee. And then I will discuss their goals. What is it that they hope to achieve during the course of the day with me, and then plan the teaching mode. And this is where the flexibility comes in. Does the trainee prefer synchronous readouts where we read the screen, share the screen together and talk about the findings and the differential considerations? Or are they more preferential for an asynchronous format where they want to review on their own and then discuss their findings with me subsequent to that? I make sure that the trainee knows when and how they can contact me, and because I want to emphasize to them that I am easily reachable throughout the course of our time together. I also plan when the trainee is going to hear from me next. And most importantly, with that first interaction, I'm going to reassure the trainee that they are not alone, that even though they don't see me, I am virtually there right by their side. So the best way to replicate that side-by-side readout experience is to be in a position where you and the trainee are viewing the same screen simultaneously. And as you're all aware, there are numerous screen sharing platforms that are available that are HIPAA compliant and have security in place. At our institution, we use MS Teams, which I find to be really helpful in engaging my trainees in discussions. So I do have a camera. I start off my day or my initial conversation with a trainee with the camera on so they can see my face, they can see that I'm not a bot. But I actually turn off the camera for the rest of the interactions because I find it actually to be a little bit distracting for me and the trainee. And at the same time, it also adds a couple extra clicks, and I want to streamline my communication with them as much as possible. So the less clicks, the better. Whatever modality you use, you want to make sure that you have appropriate internet speed and not held up by VPN connections, because the longer it takes to load a case or load the images, that's going to impact your mood and your patience and your willingness to go the extra mile to engage the trainee. So here's what I love about MS Teams is that I can initiate a readout session in just 3 clicks. So I'm already engaged in a chat with the trainee. I click the call button. I click the share button and then pick the screen that I want to share. And then within 3 clicks, I'm in business and we're already talking about the case. The other function that I really like about Teams chat is the Teams chat, where you can have a discussion back and forth with the trainee during the course of the day. And here's an example of the back and forth that I'll have with a trainee in the course of one shift. I really love that there are no links and no hyperlinks available or to hurdle through, so that I can directly show the image that's annotated, and these are preserved into perpetuity. So 2 years from now, if I remember, oh, I showed Jennifer that case of whatever, and now I want to show the trainee I'm working with today, I can go back and search it and copy that image and share it very quickly. So I love that these are preserved into perpetuity like that. Next pearl is that I want to share my process with the trainee. I want to start at the beginning. I don't want to just share the screen that shows the image with the abnormality that is the crux of the case. I want to show the screen where all of the different folders are laid out and explain to the trainee, why am I choosing this sequence first and this one second? Why is the clinical situation affecting, what I look at first, second, and third. I like to review the medical record together too. So I will share the medical record chart screen, and we'll scroll through and look at the clinical indication for the scan, look up labs together, look up path results together, so that they can observe my process. They understand how I am approaching a specific case to come to a conclusion, and hopefully they can replicate that when they're working independently on their own. I do like to make a teaching point on each and every case as much as possible. Even with a normal exam, you can probe the trainee's knowledge base. So, the indication is rule out posterior reversible encephalopathy syndrome. Well, our case is normal, but what are we looking for in terms of the pathology? What imaging findings would you be hoping to see to make that kind of diagnosis? You can go over normal and variant anatomy. And then sometimes I'll not talk about images, I'll talk about the reports and their word choices and why I chose to change this phrase or remove this section here and put it there, so that that will help them understand the communication aspect of what it is that we do. Feedback is really important, but it's also very important to do it in a constructive way and use non-judgmental tone. We are not face-to-face. The trainee does not have my visual cues, my body language to understand that I'm being silly or jokey or serious. And so it's really important to maintain a calm and non-judgmental tone when providing feedback. I am a strong advocate for positive reinforcement. I think it's really important to emphasize the great calls, not just point out the misses. And as Nina mentioned, it's really important not to qualify it as misses, but to explore how the trainee came to that conclusion in the first place. I like short but substantive exchanges, so there's no need to go on for 45 minutes about a case. You can get straight to the point and get to the meat of the matter pretty quickly, as long as the exchanges are substantive. And of course, it's important to keep in mind that you have to adjust your expectation to the level of the trainee. I love the snip tool. I find it to have been a game changer for me. It's available on both Windows 10 and Windows 11. And it has really helped me communicate imaging features to trainees in a very efficient manner. So here's an example. I have an abnormality that I want to share with the trainee. So I click my snip tool. I'm going to select the image that I'm worried about. I'm going to annotate the image and point out the finding of concern, copy that image, and then paste it into the Teams chat. And along with any commentary, I might type out and send it. Boom, it's done. I also like to share relevant teaching file cases. So let's say I have an abnormality that I think is of interest on this particular image. There are microhemorrhages in the basal ganglia, which could be hypertensive in nature based on that location. So I'm going to go to my teaching file and click all these other cool cases with similar microhemorrhages on SWI, but in a different pattern that invoke a different differential consideration. And this way, the trainee gets not just the imaging findings from the one case, but a whole plethora of knowledge from different imaging patterns based off of that one case. I like to review relevant literature together. So I also have on my desktop a series of papers that I think are really helpful to the trainee experience. And I'll share the screen and go through the manuscript with the trainee side by side at the workstation. And then, of course, I'll share the link with them so they have it for future use. Oh, sorry. And very importantly, this is how I emote. I like to add some fun by using GIFs and emojis. It might seem silly, but these tools are really the way that I can convey emotion that's lost with us not being face-to-face. It gives the trainee something to smile and chuckle about, and they will often return the favor with a clever GIF or emoji on their end, and it just helps keep the funnies going throughout the shift, and this is how we end up having a really good time. So at the end of our readout sessions, I always like to provide general feedback and then propose an action plan to move forward for the next time that they're at a workstation. For example, you did a great job on your detailed analysis of this thing, looking at the bone structures. Why don't we next time work on moving your pace in a little bit more rapid fashion, try to get through a little bit more cases through the shift if you can. I always end my sessions with any unanswered questions, and this is often followed by a very long pause, and it's important to allow that pause to go to do its thing. Do be patient. Pauses always seem to take longer in a virtual format, but this is where you might be very enlightened to find out that the trainee actually grasps concepts that you didn't think that they were aware of, or at the same time, you might find potential gaps in their knowledge that you might propose an action plan for moving forward with. So I've talked a lot about what we can do as educators to make this remote relationship work, but the trainee also does have some responsibilities to make it work as well. It's important that they be very proactive and talk and ask a lot of questions, even if they might be a little bit on the reticent side. Passivity can potentially be interpreted as a complete understanding of the material by the educator, or potentially on a darker side, it might be perceived as an unwillingness to learn. I tell my trainees, if this is not working for you, say something, let me know, tell me what I can do to make this a better experience for you. I also suggest that they wear headphones if possible. There tends to be a lot of background noise in most busy reading rooms, and it can potentially impede exchange of ideas. So sometimes trainees find it helpful to use the headphones. So why go to all this trouble? What's in it for us as the educator? Well, you're educating, and that's what we're in this business for in the first place, right? This is the thing that brings us joy, and we can do that regardless of whether we're in person or in a virtual setting. This engagement with the trainee is your social engagement. Very often we're isolated in our home by ourselves, and this is good for you as the educator, because this, is important for you emotionally, I think. It is for me, in terms of maintaining contact with other humans. And certainly making this work does validate the remote work option. I think many of us do enjoy the privilege of being able to work from home, either on a part-time basis or full-time basis, but it's important for us to show that we can make it work. And we have to be able to do our job, whether we're on site or remote. So in summary, the successful remote exchange with a trainee requires respect and empathy for that trainee's experience. If there's one point I can make, it's that communication and frequent communication is key to making the relationship work. Make your exchanges substantive, do a streamlined approach as much as you can, the less clicks, the better, and make it fun. And in the end, both the educator and the trainee will benefit. So with that, I thank you for your attention and happy to take any questions.
Perfect. Thank you so much. Those were both such excellent talks. I'm personally leaving with some really good tips for my remote teaching. We did have one question in the chat, which Nina, I think your response only went to us. So I will ask the question out loud so everyone can benefit from your response. And then if others have questions or comments or thoughts, feel free to put them in the chat or in the Q&A box and I can review them. So one question was whether you screen share throughout the day with your resident or just during the readout sessions. And maybe actually both of you could address that.
Yeah, so like I said, I don't know if everyone got my answer, but I typically will create a meeting, a Teams meeting at the beginning of the day, and I'll send an invitation to all of the residents on service, even if I'm not working with a particular resident that day. I want to be available to all of the residents in the section to ask questions. If there's not an attending in the room, maybe they need to ask me a quick question, and it's easier to just hop into a Teams meeting than call me, get me on the phone, and hope that I see the phone, that I'm answering. So I will be in that room for the whole day. I won't leave that Teams meeting, and I'll typically have my headphones on, and they'll come in and scare me because they'll say hello, and they'll come in for quick readouts, or it keeps the communication flowing, like Rose said, and it allows for just more fostering of the relationship and the partnership. And they feel like I'm more accessible to them than even sitting in the next workstation over to them, because I welcome the interaction. I ask them to please come in at any time. Yeah.
Ro, how about you?
So I'm not sure if I understand the question correctly, but I do screen share the cases that are in question during our exchange and dialogue. But I do hang up after that exchange, and then during our next planned readout session, we reconnect again. Obviously, there's different ways to go about this. Some have some methodologies, others have others that work for them, but that's just how I function.
Perfect. Another question was, do you usually let the resident be the driver, lead, and scroll through the images, or mostly are you doing the scrolling and sharing?
For the juniors, for all the residents, I will enable the control option, so I can see their mouse and they have the ability to manipulate the images from my pack screen. So it's helpful to see what they're talking about. Maybe they can't explain something clearly, or I'm missing something that they're pointing out. But I will typically ask for the seniors to share their screen, and they're presenting the cases to me, and they're scrolling through their findings, and we're going through their template and their dictation as we're reading through the cases. So it really depends on the level of training. But early on, I'm mostly doing the scrolling and showing them my methodology.
I agree. I think that the approach depends on the level of the trainee and their level of comfort, but the more senior folks that we work with are going to have more directed questions. So they're going to be like, I see this enhancing thing. What do I do about it? And I say, show me, what is it that you're looking at? And what did it look like on the prior? And what do we know about the clinical context, et cetera, to come to a decision about what to do about it. But I keep it fluid and I keep it flexible. So sometimes I'm sharing and scrolling, and other times it's the training.
Perfect. While we see if any other questions from the attendees scroll in, I'm curious from your point of view, what is like your biggest pain point with remote readouts and how you manage that?
Do you have a pain point ready to go, Ro?
Pain point, like what makes it difficult?
Yeah, what for you is the most challenging about working with trainees remotely?
When residents don't have headphones and I can hear background noise, that's the most challenging, because I can't think when that happens.
Yeah.
So technical limitations.
Yeah.
We do have one more question. How do you handle remote readouts during call and evening shifts? Do either of you do call and evening shifts?
I actually primarily do evening shifts for my work. I'm mostly an evening call person. And I do exactly as I mentioned in the talk. My approaches are the same. The call shifts tend to be with the more senior trainees. I work primarily with fellows. So we often do a lot of banter back and forth on the Teams chat about the cases. I may not comment so much about each and every single case because the volume is just quite a bit. But anytime there is a chance to make a teaching point, I will make it and then share my comments in the Teams chat. So it's the same approach, day or night.
Not so much for me. I'm more of a day gal. I'm on the day shift, but during the weekends and evening shifts that I do cover, formal readouts, at least kind of go out the window. I still create a room. I'm still available to the resident if they want to hop in and chat and talk about something. And then I will typically review most cross-sectionals with the residents that come on. Unfortunately, I don't have the privilege of working with fellows quite yet, but it's hyphenated, certainly hyphenated on the weekends because we have a lot of call or a lot of volume. But I still try and maintain the communication and availability to the residents.
There was one question about whether the institution pays for the headsets. I know at Vanderbilt, they were making sure that the reading rooms had webcams and headsets. I'm not sure about Hopkins and other institutions.
I'm sure it's quite variable. Interestingly, the workstations on site don't have web cameras. So I have a web camera and I share my videos with my face with them, but it's not always the reverse. I don't know that I mean, I think every institution has like funds for trainees and faculty that you can use to buy such equipment, if you find it helpful to you. But like, I don't think you can give a blanket statement across multiple institutions for that kind of question.
Okay, perfect. Hopefully people can still hear me. My landscaper is right outside my office window. The last question that came in was, how have you been able or not to get buy-in through the faculty on establishing these practices more uniformly? Any challenges?
Go ahead, Ro.
Oh, I think that with time, since COVID, I feel like my colleagues have also recognized the benefits of being able to work remotely, and we've all sort of figured out collectively a way to try to make it work. And some of us are probably more proactive about it than others. But I think that given the fact that we all have the option to work remotely from one time to another, we're all doing our best to make it work. So we all benefit, and so we all put in our best effort.
Yeah, similar at Vanderbilt, and I'm sure Shanna, you can jump in and add to this. You probably know more, but at Vanderbilt, we've been over the past year trying to incorporate more and more teaching tricks and tips. I know we had a grand rounds in January talking about best practices in teaching. So yeah, we have quite a few faculty that are remote. We have another MSK faculty in our section that is remote as well. And we all seem to have our own methods in applying remote teaching, but it seems like there is quite a bit of buy-in from our institution. And Shanna, I'm not sure if you have more to shed light on that. But I think so. I think it's moving in the right direction.
Yeah, I definitely agree. I would echo what you said. I feel like, I think like a theme of both of your talks was intentionality. And I think that our institution has done a good job of hiring remote people who are, have a background in education and will be intentional in their educational interactions. And so I think it's made it, pretty successful from my standpoint. We have one question that just came in. I feel like one loss in remote education is that residents have fewer role models of how to interact with clinicians and techs around the department, coach them on the phone, etc.
So at Hopkins, it turns out that a lot of our communications occur electronically through the Epic chat. We use Epic, as I'm sure many institutions do. And so that's actually the first line of communication that techs reach out to our teams for. And we are included in those chats. And so I can actually observe the dialogue between the trainee and the technologist. And there have been times when I feel like, oh, I wasn't so great on that interaction. I'll try to like smooth things over with my input, but I'll also separately and aside talk to the trainee about their manner and their approach to their discussion with the technologist. But I also make it a point to respond to the technologists and providers just as much as the trainees do, so that they can see how I respond and show respect to the CT technologist or whatever, those kinds of things. So I think I am able to emulate and serve as a role model in terms of communication, even though we're not face to face, because it's mostly on an electronic basis currently.
Yeah, I completely agree and echo of what Bro said. I will oftentimes take phone calls or consults with the resident on the line with me, on the team's phone call with me. I'll put things on speaker and they can hear the interaction. They can also interact as well. That's gone pretty well. And I include them in all of my challenges throughout the day. So they bear witness to every single challenge and how I navigate that. So they're witnessing and experiencing that. I'm pulling them with me. I'm dragging them through everything. But I don't, as a remote faculty, the techs and admin have the ability to reach me, to contact me. So it's not too difficult to pull the resident or the trainee into that conversation. We also have electronic communication through our PAC system, and we can group chat and all of that. So I haven't really found that to be all too challenging. Maybe in instances where there's like a face-to-face heated conversation that might need a little bit of finessing, that's a little bit difficult remotely, but I think it's pretty easy to incorporate that.
Perfect. Yeah, I agree. One of my biggest challenges going fully remote was ultrasound, because the sonographers will call you for checks, and I'm physically remote from the resident. And sometimes you're on with a first-year resident on their first day or their first week. And so we would do the checks like through Teams with the sonographer on speakerphone. So that way we were kind of doing it simultaneously. It just takes some getting used to, but once you do it, it becomes very seamless. Okay, we have 4 minutes remaining. I do want to leave a moment of silence in case people have any last minute questions that they're typing in. Otherwise, I do want to thank our speakers for putting together such wonderful presentations, and our attendees for such awesome engagement. And, I think we can continue to learn from each other and share all of these tips and tricks. And someone said that they do part-time remote nuke med, and it works pretty well. So.
Yay.
Awesome.
We have neuro, MSK, abdomen, nuke med. Wonderful.
Any remote mammo out there.
A little trickier, but
yeah.
All right. Well, thank you, everyone. We'll conclude and give you back a couple of minutes of your time. And we look forward to seeing you in February for the next roundtable. Thank you.
Thanks, everyone.
Take care.
Bye-bye.
Bye.